Hi guys, good evening, good evening, good evening. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Quick feedback. So we're back with our own setup. Okay. Hi, good evening, good evening, good evening. So today we're going to have a very short session. We're going to talk about one disease in the stomach and then we'll wrap it up because I'll start CA stomach, that is from the next session onwards. So we're going to talk about a very small topic which is quite interesting and important, that is called as the Menetrier's disease of the stomach. Yeah, good evening guys. Yeah, let's roll it down. Let's roll it down. Okay. So we're talking about the Menetrier's disease. Now, this Menetrier disease is also commonly referred to as the hypoproteinemic gastropathy, also referred to as the hypoproteinemic gastropathy. The Menetrier disease is also referred to as the hypoproteinemic, also referred to as the hypoproteinemic gastropathy. We've been telling you that if you follow the series, you don't need to read Bailey because it is the entire replica of Bailey. If at all you want to read Bailey, once you see a video lecture, go back. It's more like a revision for you, right? It does help you in that way. So I assure you, the series is more than enough in order to complete your Bayesian law, right? So talk about the Menetrier's disease, which is also called as the hypoproteinemic gastropathy. Now, if you look at the whole concept of the Menetrier's disease, if this is the representation of the esophagus, this happens to be the stomach, this happens to be the gastroesophageal junction. We told you that this is going to be the cardia, this is going to be the fundus, this is going to be the body, and this happens to be the pyloric antrum. So this is the cardia, this is the fundus, this is the body, this is the pyloric antrum of the stomach. Now, when you look at the inner surface, just for the sake of understanding, these are your mucosal folds which are going to be present. This is the rugosities in the stomach, which are nothing but the mucosal folds, which are going to be the mucosal folds inside the stomach, which is going to be the mucosal folds inside the stomach. We don't know the exact pathophysiology. We'll try to show, put a little bit of light onto what is happening in Menetrier's disease. There is hypertrophy of the mucosal cells or the mucus producing cells, especially in the area. This is the cardia that you have. Talking about the fundus, the body, and the pyloric antrum that you have. This is the cardia, this is the fundus, this is the body, this is the pyloric antrum. You see the mucus producing cells here remains normal, but in the fundus they become hypertrophied, and in the body they also become hypertrophied, but in the pyloric antrum they remain normal. So the whole problem in the Menetrier's disease, there is going to be hypertrophy. There's going to be the hypertrophy. There's going to be the hypertrophy of mucus. There's going to be the hypertrophy of the mucus cells, and this hypertrophy usually occurs in the body and the fundus of the stomach. This usually occurs in the body and the fundus of the stomach, right? If you look at the entire pathophysiology, the who is the villain behind the entire story, if you analyze who is the villain behind the entire story, it all starts, if I say the pathophysiology, let's quickly discuss about the pathophysiology. When we talk about the pathophysiology, when we talk about the pathophysiology, it is because of your TNF alpha, right? This is your transforming growth factor. This is your transforming growth factor. This is going to be your transforming growth factor alpha, right? Now this TNF alpha, it is going to have an overexpression. There is an overexpression of TNF alpha that is going to occur. Now, why is this overexpression is going to take place? Now, if you talk about the context or the cause for this overexpression, one is the primary cause, another one is the secondary cause. The primary cause, nobody knows it, so hence we are going to call it as idiopathic. We will call it as idiopathic. Secondary cause varies in children as well as in adult. In children, it is because of cytomegalovirus. It is because of CMV virus infection. In adults, it is usually seen secondary to H. pylori infection, right? So this TNF alpha, which is going to have an overexpression, usually it is idiopathic, but in few cases we can call it as a secondary cause. In a secondary cause in children, it is because of a cytomegalovirus infection. In adults, it is secondary to H. pylori infection. It is going to be association with H. pylori infection, right? Now, what is going to happen with this TNF alpha? This TNF alpha's overexpression is now going to cause activation of EGFR. This causes activation of a growth factor which is called as an EGFR. Now, what is this EGFR? Anybody who wants to comment what is this EGFR? If you have done your patho, you'll be able to tell me quite easily what is this EGFR. What is this EGFR? It is your epidermal growth factor receptor. It is your epidermal growth factor receptor. It will cause activation of EGFR, that is called as the epidermal growth factor receptor. Now this EGFR, when it gets activated, so the activation of EGFR will now result in excessive proliferation of cells, which is what we call it as the foveolar cells, right? This is going to lead into the foveolar cells, or we call it as the foveolar hyperplasia. This is what we call it as the foveolar hyperplasia. Now, what is this foveolar hyperplasia? When we talk about the foveolar hyperplasia, this is hyperplasia of the mucus producing cell. This is hyperplasia of mucus producing. It is the hyperplasia of the mucus producing cell, right? So what is the problem if there is hyperplasia of the mucus producing cells? To understand that, you need to understand the gastric pit. Let's say this is how a gastric pit would look like, right? Now this is what we call it as the neck of the gastric pit, and on the surface of the neck of the gastric pit, these are your mucus producing cells. These are your mucus producing cells. Now rest all the different cells which are present, which are going to be your parietal cells, chief cells, enterochromaffin like cells, all these are present below the neck of the gastric pit. Now when there is a hyperplasia of the gastric producing cells or the mucus producing cells, as they become hyperplastic, one, the number of the mucus producing cells are increasing. Second, they are now going to block the gastric pit. When they block the gastric pit, the secretions which are going to be produced by all the other components are now going to be trapped. They are not going to be released. And more importantly, you will notice that the mucus that is going to be produced will now increase because of the mucus producing cells are now becoming hypertrophied. So one, you will see there is excessive amount of mucus that is being produced, and on the other hand, you will see all the secretions which are present, they will not be able to escape out because the gastric pit is now getting blocked, right? See, once the the mucus secretion is increasing, right, another one is blocking the gastric pit, hence the problem is going to occur, right? So what is going to happen? Now, because of this foveolar hyperplasia, that is hyperplasia of the mucus producing cells, the effect that you're going to see, number one, there'll be increase in mucus secretion. There'll be increase in mucus secretion, right? Now, this mucus will be rich in protein. It will be rich in protein, especially albumin. Now, because of excessive secretion, there will be excessive loss, and this will result in diarrhea. And this diarrhea will be protein losing diarrhea. So, hence, it is going to be a protein losing enteropathies as well, or I can say it is going to cause hypoproteinemia, right? So, diarrhea associated with hypoproteinemia. It is going to be associated with hypoproteinemia. Second, it is now going to block the secretions of your parietal cells. Now, as we all know, parietal cells are responsible for secreting hydrochloric acid and the Castle intrinsic factor. So, hydrochloric acid is going to reduce. This is going to result in hypochlorhydria. This is going to result in hypochlorhydria. And if the Castle intrinsic factor is reduced, this is going to result in B12 deficiency. This is going to result in B12 deficiency. Hi Santosh sir, good evening. I'm just taking your topic, I guess. It's more like a medicine topic, but because it is there in the Bailey, I'm just trying to do a little bit of justification. Please forgive me if I'm trying to, meddle a little bit with your physiology and your concepts. I'm not that strong. Santosh sir, please correct me if I've gone anywhere wrong, but this is what I understood. Okay. Yeah, Santosh sir, please, if you feel to comment anything, just be that. Right. So as the mucus secretion is increasing, there is going to be damage. I mean, there is going to be blockage in the parietal cells. There will also be blockage in the chief cells. Right? The chief cells which are present will also not be able to have their secretion. So there will be deficiency of pepsin. Now, when the pepsin is going to reduce, this is going to cause decreased protein absorption, so resulting in hypoproteinemia. Now, this hypoproteinemia is usually seen more commonly in albumin. This will be usually associated with albumin deficiency. Okay. Now, if you look at the whole summary of what we have tried to give you across in terms of Menetrier disease, it is because of an overactivation of your TNF alpha, which causes activation of EGFR. EGFR activation will cause proliferation of your mucus producing cells, which are now going to block the gastric pit. Blockage of the gastric pit will result in excessive mucus secretion, because the blockage is because of proliferation of mucus producing cells, and then you have damage, or I can say blockage of parietal cells, or the secretions are stopped and the chief cell secretion are going to reduce. They're going to reduce, right? So because of this, if you look at the clinical presentation, if you look at the clinical presentation of the Menetrier disease, in the clinical presentation of Menetrier disease, there will be features suggestive of hypoproteinemia. Now, in the hypoproteinemia, there will be presence of edema that is going to be present. This edema is because of hypoalbuminemia. This is because of hypoalbuminemia. Okay. Now, apart from that, it is going to be associated with hypochlorhydria. It is going to be associated with hypochlorhydria. There will be excessive mucus secretion, which will present to you with diarrhea, which will be associated with diarrhea. There will be B12 deficiency, which is associated with megaloblastic anemia. There will be megaloblastic anemia. See, we call it as pernicious anemia when there's a B12 deficiency, especially if it is associated with an autoimmune destruction of the parietal cells, right? So here there is hypoproteinemia, hypochlorhydria, diarrhea associated with your megaloblastic anemia. Remember, as a very important note pointer, the Menetrier disease increases the risk for adenocarcinoma of the stomach. It increases the risk for adenocarcinoma of stomach. They be associated with the adenocarcinoma of the stomach, right? This B12 deficiency can be associated as megaloblastic, but when the B12 deficiency occurs because of autoimmune destruction of parietal cells, which can happen in Menetrier disease. In the Menetrier disease, remember, it can associate with autoimmune damage of parietal cells. Now, if there is an autoimmune damage of parietal cells, there will be B12 deficiency. Now, when the B12 deficiency occurs because of this is what we call it as pernicious anemia, right? This will result in B12 deficiency. And when the B12 deficiency occurs from here, this is what we call it as pernicious. This is what we call it as pernicious anemia. And remember, pernicious anemia actually increases the risk for development of the adenocarcinoma of the stomach. It increases the risk for adenocarcinoma of the stomach, right? Now, when you talk about the Menetrier disease, there are different subsets of investigations. But when you look at the investigations per se, in the investigation, you can do an upper GI endoscopy, right? And when you do an upper GI endoscopy, you would see there is presence of hypertrophied mucosal folds. You'll be taking biopsy from the hypertrophied mucosal folds. This is basically to rule out the malignancy. This is to basically rule out malignancy. Now, in terms of management, eventually, because it's a pre-malignant condition, you all know what you have to be doing. In a pre-malignant status, I know this is going to increase the risk for development of the malignancy. You will address it, but initially I will try to give a patient with protein supplementation, that is albumin supplement. You can, because it is because of excessive increase in mucosal secretions, you can try giving octreotide, which is like a somatostatin analog, but they are not very effective in this context. So you'll give protein supplementations, you will give supportive care, you'll give supportive care. But if they ask you what is a definitive management, what is your definitive management? Now for the definitive management, it is going to be prophylactic total gastrectomy. It is going to be a prophylactic total gastrectomy. Now, if the patient is unwilling for this, if the patient is unwilling for this, if patient is unwilling, if the patient is unwilling for surgery, in that context, then you have to go with annual upper GI you'll go ahead with annual upper GI endoscopy. You'll go with annual upper GI endoscopy. But a supportive care, if there is diarrhea, you give antidiuretic, you give somatostatin analogs like octreotide. If the patient is hypochlorhydria, that is hypochloremia is there, you give chlorine supplementations. All that comes under supportive care. But eventually, because it's a pre-malignant condition, I would like to go ahead with gastrectomy. If the patient is not willing for gastrectomy, give the patient for annual upper GI endoscopy, right? So it's a surveillance endoscopy that you need to, right? Now the carry-home message for your Menetrier disease is basically to understand this particular slide, right? This is where usually when they want to ask you a trick question, especially if you're writing a competitive exam, this is what is going to be important and relevant, right? Did you all understand? Yeah, guys. Right. So far, any questions? Quick feedback. कोई सवाल, कोई शक, anything? Great. Uh, just to give you perspective about what is important. देखो अभी आगे चल के ना जैसे जैसे आप फाइनल ईयर खत्म करोगे, you'll go into internship, फिर आप नीट पीजी INICET इन सब की पीजी की तैयारी करोगे, उस टाइम पे ना there's a lot of thing that you have to process it. तो होता ये है कि अगर आपका फाइनल ईयर का फाउंडेशन ठीक नहीं है ना, तो फिर आपके नीट पीजी वाले प्रिपरेशन वाले फेज में बहुत दिक्कत होती है. Now एक बहुत interesting thing that we have observed, and this is something that we found out recently, मतलब it's been there but it's more evident nowadays, कि देखो हर वो बच्चा जो पीजी करना चाहता है, ठीक है, बेटा BLS नोट्स हैव बीन अपलोडेड यस्टरडे, अगर नहीं किया होगा तो आज वापस कर देंगे, कोई दिक्कत नहीं है, ठीक है. अच्छा, जैसे मैं बोल रहा था, हर वो बच्चा ना जो आगे जाके पीजी करना चाहता है, हर बच्चे की दो ही ख्वाहिश होती है ब्रॉडली, अगर आप देखोगे, या तो उसको मेडिसिन करना होता है या तो उसको सर्जरी वाला ब्रांच करना होता है. आइदर यू आर गोइंग इनटू अ मेडिकल स्ट्रीम और यू आर गोइंग इनटू अ सर्जिकल स्ट्रीम. यही दो चीजें हैं जो यूजुअली आप अपने आप से रेजोनेट करते हो, ठीक है. लेकिन प्रिपरेशन वाले फेज में ना यही दो सब्जेक्ट है जो मोस्ट कॉमनली लेफ्ट अराउंड होते हैं. मतलब बच्चा छोड़ देता है, बोलता है यार ये नहीं पढ़ेंगे, बाकी पढ़ लेंगे. और अगर आप ये सोच रहे हो कि आपका नीट पीजी एग्जाम या फिर आपका पीजी एग्जाम और INICET एग्जाम आप मेडिसिन सर्जरी पढ़े बिना निकाल लोगे, देन इट इज अ मिथ बेटा, ठीक है. मेडिसिन सर्जरी इज नॉट टू इंडिविजुअल सब्जेक्ट्स. देखो 19 सब्जेक्ट्स में से 9 से 10 सब्जेक्ट का भार आपका मेडिसिन उठाता है, 8 से 9 सब्जेक्ट्स का भार आपका सर्जरी उठाता है, ठीक है. सो इफ यू रीड योर मेडिसिन सर्जरी कंप्लीटली एंड टू दैट कॉम्पिटेंट लेवल, आपके इफ इवन इफ आई टेक ऑल द ओवरलैपिंग सब्जेक्ट्स, आपके 14 से 15 सब्जेक्ट आराम से कवर हो जाते हैं बाय डूइंग मेडिसिन सर्जरी अलोन, ठीक है. तो ये गलती नहीं करना है कि यार मैंने मेडिसिन सर्जरी अच्छे से पढ़ी नहीं है तो इसको छोड़ देते हैं, बाकी 17 सब्जेक्ट पढ़ लेंगे ताकि हमारा नीट पीजी INICET में निकल जाए, लेकिन जाके लेना मेडिसिन ही है या फिर सर्जरी है, तो क्या फायदा उस चीज का जो आपने अपने कोर सब्जेक्ट्स में टाइम बिताया नहीं है, ठीक है. तो जस्ट टू गिव यू पर्सपेक्टिव्स व्हाट इज हैपनिंग रीसेंट, हमारा जो आई जस्ट शो यू व्हाट इज द लेटेस्ट मार्क्स डिस्ट्रीब्यूशन. बेटा ये आपका एक a very important wheel that we have. It is a pie chart. In fact, ये हमारी जो MedEd की टीम है, they have created it. They took a lot of hard work behind it. Last 5 साल के आपके नीट पीजी और INICET का जो मार्क्स डिस्ट्रीब्यूशन है वो कुछ ऐसा दिखता है, ठीक है. तो नीडलेस टू टेल यू, ये वाला चंक बहुत बड़ा है. इसमें से अगर आप देखोगे सबसे मोटा चंक ये येलो वाला है. हमारे संतोष सर भी देख रहे होंगे तो ही विल बी वेरी वेरी कीन एंड हैप्पी अबाउट इट कि मेडिसिन जो है वो 14% ऑफ योर टोटल पेपर एट एनी गिवन पॉइंट है. तो 14% ऑफ XYZ नंबर अगर आप क्वेश्चन का लगा लोगे ना, तो 40 से 50 क्वेश्चन आपके मेडिसिन के हर साल आते हैं. सेम विथ सर्जरी है, 12.5% है, तो यहाँ पे भी 40 क्वेश्चन कहीं नहीं गए. मेडिसिन सर्जरी पुट टुगेदर इज 80 क्वेश्चन. आपके 200 क्वेश्चन का तो नीट पीजी और INICET है. अगर आप 200 में से 60 से 80 सवाल आपके सही जा रहे हैं बाय डूइंग टू सब्जेक्ट्स, नथिंग रॉन्ग इन इट. इनफैक्ट दीज आर द टू मोस्ट इंटरेस्टिंग सब्जेक्ट्स. तो यहाँ पे टाइम लगाना बनता है. इन्वेस्ट करो. आप यहाँ पे इन्वेस्ट किए जा रहे हो अपना टाइम, जो साला 1%, 2%, 1%, 2% है, इसी की गेम है. ये आपके चिल्लर पेनी स्टॉक्स हैं, ठीक है. इनसे हो सकता है कि आप अमीर बनो ना बनो, लेकिन बेटा ये आपके ब्लू चिप्स निफ्टी वाले स्टॉक्स हैं. यहाँ पे इन्वेस्टेड रहोगे तो लाइफ लॉन्ग आपके उसमें काम आएगा, राइट. तो माई सिंसियर एडवाइस टू एवरी सिंगल स्टूडेंट who is planning to prepare for NEET PG, INICET और PG for any competitive exam, बेटा इस चार्ट को एक बार जरूर देख लेना. इट्स एन आई ओपनर दैट यू नीड टू अंडरस्टैंड वेयर टू फोकस एंड वेयर टू लेट गो, ठीक है. तो कीप दैट इन माइंड, मेक श्योर यू वर्क हार्ड ऑन दोस, ठीक है. एंड विल ट्राई, आई कम नाउ एंड अगेन, हर बार आकर मैं आपको रिमाइंड कराऊंगा कि बेटा मेडिसिन सर्जरी पढ़े बिना कोई इंसान डॉक्टर नहीं बन सकता, ठीक है। तो प्लीज डू नॉट इग्नोर दीज टू सब्जेक्ट्स या कोर। उसके साथ साथ हमारी ऑप्शन का नहीं है 10%, मतलब उनको हम कैसे भूल सकते हैं, ये हमारे पूरे मेडिसिन का लव है, तो भाई उनको वो दर्जा मिलना चाहिए, तो ऑप्शन का ही नहीं है। फिर हमारे पीएसएम वाले आ जाते हैं, बोलते हैं कि भैया सबको जोड़ने के लिए एक ग्लू चाहिए, वो पीएसएम है। तो अगर आप इतना क्लट निकाल दोगे ना, ऑलमोस्ट 50% है यार ऑप्शन का ही नहीं, जनरल सर्जरी, जनरल मेडिसिन और पीएसएम मिला के, ठीक है। तो इफ यू आर गुड विद दीज सब्जेक्ट्स एंड यू ऐड अ बिट ऑफ माइक्रो फार्मा पैथो, तो आपका 70% पोर्शन तो कवर हो गया, ठीक है। व्हाट इज मेडिसिन? मेडिसिन इज नथिंग बट पैथोलॉजी, बायोकेमिस्ट्री, फार्माकोलॉजी, माइक्रोबायोलॉजी, ये सब मिला के आपकी जनरल मेडिसिन मिलती है। जनरल सर्जरी में क्या है? इट इज गोइंग टू बी अ कॉम्बिनेशन ऑफ एनाटॉमी, योर फिजियोलॉजी, योर पैथोलॉजी, योर फार्माकोलॉजी, ये सब के साथ आपका थोड़ा बहुत मेडिसिन ऐड कर दोगे, आपका जनरल सर्जरी हो जाएगा, ठीक है। तो ऑल दीज इंटररिलेटेड इंटरकनेक्टेड सब्जेक्ट्स, यू हैव टू मेक श्योर कि आप थोड़ा टाइम स्पेंड करो, पढ़ना शुरू करो। बेटा कुछ भी शुरू करने में दिक्कत होती है, ठीक है, एंड वंस यू कीप गोइंग इट बिकम्स इजियर। अच्छा, एक बहुत इंटरेस्टिंग सवाल था, आप ही में से किसी बच्चे ने पूछा कि सर अब तो आपने मतलब यू फिनिश्ड योर एमबीबीएस, आपने एमएस कर ली, आपने एमसीएच कर ली, ठीक है, आप फलाने का जो भी कर रहे हो, डू यू स्टिल रीड और नॉट? बेटा आई एम स्टिल डूइंग माय फेलोशिप, और जस्ट टू गिव यू पर्सपेक्टिव्स, अभी क्या पढ़ रहे हैं, ठीक है, जस्ट आई जस्ट शो यू व्हाट वी आर रीडिंग राइट नाउ, ठीक है। आपको मैं पढ़ा रहा हूँ, ये हमारी जो टेक्स्ट बुक्स हैं, दिस इज द बेली एंड लव। तो बेली एंड लव सिर्फ सर्जरी के लिए बता रहा हूँ, ये आपकी वॉल्यूम 1 है और ये आपकी वॉल्यूम 2 है। तो अभी मैं आपको ये दो किताबें पढ़ा रहा हूँ, आप बोलोगे कि मेडिसिन में ये दो किताबें पढ़ लोगे इन योर एमबीबीएस, इट इज गुड इनफ टू लर्न योर सर्जरी, दैट इज ट्रू, बट एज यू गो द लाइफ गेट्स टफर एंड डिफिकल्ट। अब एज ऑफ नाउ, हाउ मेनी बुक्स एम आई रीडिंग? आई जस्ट शो यू द नंबर ऑफ बुक्स दैट आई एम रीडिंग राइट नाउ, ठीक है। तो आप बोलोगे सर कितनी किताबें हैं, ठीक है। तो लेट्स गेट टू अक्रॉस, दिस इज एक किताब, आई एम जस्ट गोइंग टू पुट इट हियर, ये दिख भी नहीं रही है, ठीक है। I will bring few more that I'm reading right now so that you understand it better. Right, so this is book number 1, this is book number 2. तो दो किताबें यहाँ पे, ठीक है, अभी भी खत्म नहीं है, ठीक है। This is book number 3 which is here. अच्छा, just to show you the perspective, आपको दिख नहीं रहा है तो I'll show you across here. थोड़ा सा इसको सेंट्रल दर्जा देते हैं, कितनी किताबें हैं। तो आई होप यू आर एबल टू सी नाउ, थोड़ा थोड़ा दिखना शुरू होगा। तो 3 किताबें ही होगी, ठीक है। दिस इज व्हाट द करंट, एंड दिस इज द 4th बुक दैट आई एम रीडिंग, दिस इज द 5th बुक दैट आई एम रीडिंग, ठीक है। आया 6th वन, इनफ लग रहा है? नहीं अभी तो शुरुआत है, ठीक है। दिस इज द 7th वन, दिस इज द 8th वन, ठीक है। फिर 9th वन, ठीक है। ऑलमोस्ट राइट पे, बस है नहीं, कुछ और बची है। तो दिस इज माई 11th टेक्स्ट बुक एंड दिस इज माई 12th टेक्स्ट। तो अभी के लिए ये मेरी जो नेक्स्ट 1.5 साल का जो मेरा टारगेट है वो ये 12 किताबें। दीज आर फ्रेशली बाइंडेड न्यू बुक्स, दीज आर नॉट द ओल्ड वंस। तो द लव ऑफ द बुक्स विल कंटिन्यू टू बी देयर। अगर बेटा बनना डॉक्टर है और बनना बड़ा डॉक्टर है और अच्छा डॉक्टर है, बेटा यही है जो आपके काम आएंगी, ठीक है। बाकी लोग प्राइड करते हैं कि मेरे पास ये गाड़ी है, वो घर है, ये पैसा है, ये है। यार अपना प्राइड ये है, ठीक है। दिस इज व्हाट वी प्राइड अपॉन, दिस इज व्हाट वी एक्चुअली, लोग अगर किसी को हर किसी को अपने फ्लेक्स करने का तरीका अलग है, कि अपना फ्लेक्स करने का स्टाइल है, ठीक है। तो stay true to this, ठीक है। as you grow and you build the inbuilt love for these books, ठीक है, जैसे जैसे आपका टाइम चलता रहेगा वैसे वैसे ये प्यार बढ़ता रहेगा, एंड ट्रस्ट मी दिस इज द बेस्ट बॉन्ड दैट यू कैन हैव फॉर योर लाइफ। किताब खुलती है, पढ़ते 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 द अमाउंट ऑफ नॉलेज दैट यू गेन एंड यू ट्राई टू इम्पार्ट एंड यू ट्राई टू पुट इट अक्रॉस, दिस जस्ट ग्रोस, ठीक है। तो आई वुड स्ट्रांगली रिकमेंड कि किसी चीज़ से प्यार हो या ना हो, किताबों से ज़रूर प्यार कर लेना, क्योंकि कुछ रहे ना रहे, ठीक है, this will remain for your life, ठीक है, so trust me, this is the best companion that you can have. तो कुछ खत्म नहीं होता भाई, ठीक है, तो if you have understood this is what medicine is all about, तो शॉर्टकट नहीं है बेटा, लाइफ में हर जगह शॉर्टकट मिल जाएगा, लाइफ में हर वो गली पतली मोटी मिल जाएगी, लेकिन अपने यहाँ पे एक ही गली मिलती है, वो ये वाली मिलती है, ठीक है, तो इफ यू वांट टू हैव योर जर्नी स्मूथ, दिस इज व्हाट यू नीड टू इनकलकेट, ठीक है, इम्बाइब इट, हैव फन, यू लाइक इट, ठीक है। संतोष सर आप अभी भी, अरे यार संतोष सर, अच्छा ये तो मेरी अभी की, इफ संतोष सर अपना फ्लेक्स करने लगेंगे वो अलग हो जाएगी सर। सर ये मतलब अच्छा, देखो बेटा, इनके साथ साथ ना एक साइड एडवांटेज मिलता है, इफ यू आर गुड विद दिस, नो, फिर वो BMW, वो मर्सिडीज बेंज, वो पोर्शा जो आपके संतोष सर बता नहीं रहे हैं, ठीक है, फिर वो घर, वो रुतबा, वो सब आराम आराम से आता है, ठीक है। तो बेटा जस्ट टू गिव यू पर्सपेक्टिव, किसी को डराने की कोशिश नहीं कर रहे, बट दिस इज द फ्लेक्स दैट वी हैव। Chalo. So that's it for today. Thank you so much for joining, guys. We will resume back next week with carcinoma stomach, chest, as well as upper GI bleed. So next week के तीन topics ये हैं. Then we'll be done with your stomach, and then we'll start with the intestines. Right. A lot of love and respect to every single buddy who's watching. Thank you so much for all the support that we have. You know where to get the notes. जितना भी हमारा जितना surgical lecture का notes है, you'll be seeing on our MedEd channel as well as on my channel, that is the surgery guy. Follow it on the Instagram as well as Telegram. And Santosh sir, I'm going to get a call after the class. We're going to talk about it. Right. Thank you so much. Good night. Take care. Have fun. Bye bye.